Hi, this is Larry Bauer, Chief Executive Officer of the Family Medicine Education Consortium, and I'm joined today by Dr. Rick Streiffer, a family physician who's Professor of Family Medicine and formerly Dean of the College of Community Health Sciences at the University of Alabama. Dr. Streiffer, thanks so much for joining me today.
Sure, my pleasure.
So I want to talk with you, actually pick up a conversation that we were having a few days ago about the medical students coming from the Cuban medical school, medic, through the ELAM program. You were saying some things to me about the quality of those students, your experience with those students, that I thought was really very meaningful, and I thought other people should learn about this. So can you tell me about your experience with those students?
Sure. Actually, my introduction to this medical school called ELAM, which is an acronym for the Spanish of Latin American School of Medicine, goes back to 2009. I've had a longstanding interest in primary care workforce issues, particularly in rural communities and other underserved communities. And I was actually at a HRSA conference the summer of 2009 with a bunch of other family physician educators, and had a conversation over dinner with Art Kaufman from New Mexico, who you probably know. And he told me that he had just returned from Cuba, and told me a little bit about these medical students, these Americans who were studying there, which I knew nothing about. I had no idea that Americans could even travel to Cuba, more or less, and here there were some that were studying medicine there. And it was fascinating. I found myself in October of 2009 on a trip to visit it, and I've been fascinated ever since. So it turns out that this is a medical school for non-Cuban. Cuba has 25, 26 medical schools for Cubans. But this is one for non-Cubans that they started after the hurricanes devastated Central America in 1998, specifically to train non-Cubans. Rather than just sending Cuban physicians and nurses around the world, they had the idea, well, let those countries that need doctors send us their young people. We'll train them, and they can go home and serve where needed. And our commitment is, on Cuba side, will be to train them. And the commitment of these young people in their countries will be to place them in areas of need. So this started off mostly for South America, Central America, then some African countries. And apparently a Cuban delegation was speaking to a U.S. congressional delegation explaining this. And Benny Thompson, who is an African-American congressman from Mississippi, basically said, we have the need for doctors who will serve in underserved areas. And in essence, the Cubans said, fine, send us your students and we'll train them. And it was not a simple process, but the process did begin whereby these students could register or apply to this medical school through a nonprofit in the U.S., enroll in this medical school free of cost. They get basically a full scholarship. And they get an excellent training that's actually quite different from American training, but very in sync with what family medicine is all about. And they are not traditional in any sense of the word compared to American medical students. Many of them could have gone to any medical school if they wished, but they didn't find American training appealing. It didn't meet their interests, their understanding of the need of American communities of need, number one. Secondly, many of them couldn't afford to go to American medical schools or even to apply, because many of them come from socioeconomically deprived backgrounds. Majority of these students are also minority or underrepresented in medicine, either African American or Latino or Hispanic minority background. So they are quite different, both in their sense of commitment to the underserved and in their background compared to Americans. And then on top of that, they get this training, which is not like American training. It is community-based. It is longitudinal in nature. It is highly clinical, hands-on, as opposed to technologically oriented. yet very scientific, and it is very biopsychosocial, with a great deal of commitment to simultaneous integration of the social sciences, the psychological sciences, along with public health at the same time that they're getting their medical training. So it's a fascinating model of medical education.
So I first learned about this school and these students about 5-6 years ago. We've been giving scholarships to the students, 3 or 4 students per year, so that they can learn a little bit more about family medicine. The school, Elam, pays for them. And we've been working with Peter McConerty, a family physician up in the New England area, who's been kind of a liaison between us and them. And what really impresses me is not only the things that you mentioned, but also they've made a commitment to return to the United States to serve a community like theirs. So they're getting a free education, which is quite a benefit, but with a commitment to come back and serve a community that is underrepresented or underserved. It just seems to me a remarkable story.
Yeah, and so far the product, if you would, from Elam of American graduates has in fact fulfilled that expressed commitment. I don't have the data in front of me, and it's not complete. It's actually being analyzed, but about 3/4 to 80% of the Elam U.S. grads who have finished there and have entered into a residency in the United States have pursued family medicine, general internal medicine, or general peds, mostly family medicine. A small percentage, and I actually think it's less than that, 20%, have gone into other fields like emergency medicine or surgery. And in fact, something like 75 to 80% of them are also, and maybe higher, again, I don't have the data in front of me, are in community health centers, in FQHC practices, and practicing in health professional shortage areas. So they are, in fact, fulfilling their commitment.
Right.
We all know that every applicant to medical school, virtually, says they want to be a primary care doctor, and they do it because they want to serve people who need it. Yet we also know that not all those students really mean it, that not all these students really have the experience to speak to that, and certainly not all of them by any means enter primary care or serve in communities of need.
Right.
Whereas this cohort does seem to be genuine about it and to actually be fulfilling that intent.
So if we were to include this school in the ranking of production to family medicine in particular, as a measure of people actually going into primary care, this school would actually be at the top of all the Caribbean schools and the top of all U.S. allopathic and osteopathic schools. They'd be number one, with the possible exception of McGill up in Canada. They would be at the very top in terms of percent by percent producing students to family medicine. I think that's fascinating.
Yes, at least the Americans that are attending Elam. You need to understand Elam
Right.
is a huge school. It has over 10,000 students enrolled because they spread out around Cuba for the clinical years. The American component is a relatively small number. I think there's just over 100, maybe 120 Americans currently studying at Elam. But yes, when you look just at the American subset, it would clearly be one of the leaders in production, not only of future family physicians, but of underrepresented in medicine,
right,
future family physicians, which I think is equally
right.
important.
So when we were talking, you also mentioned what your experience was like with them when they came into your residency program. Could you talk about that?
Yeah, so in the early years when Americans started going down there, the Cubans really did not know how to help those students be successful. in the American perspective, at least. They certainly were always good Cuban students. They were successful academically from the Cuban perspective, but the training is so different and the evaluation is so different. They don't take multiple choice exams. They don't have these standardized step-like exams there. They actually are examined by being watched, a really radical idea in the United States,
there you go,
by their professors.
Yep.
They have to present cases. They have to do comprehensive orals, that type of thing. And so the Cubans and the Americans down there initially learned quickly that they had to do more to prepare them to come back to the U.S. So in the last number of years, American educators have, and this nonprofit that you mentioned earlier called MEDIC, have helped to support these students by getting them step exam preparation materials, by getting them textbooks, because textbooks are short down there. MEDIC has also facilitated the type of thing that you are doing, which is to host students during the summers when they're off to come and experience American medicine, which is quite different, hospital-based, technologically oriented, this sort of thing. So the most recent graduates of ELAM have done much better and successfully transitioned to the U.S., but there's still a stigma attached to going to the school in the Caribbean. And there are still struggles for some of these students because they're not immersed in the American style of evaluation throughout medical school. It appears that, and this has nothing to do with their capability, their intelligence, or anything. It's like the rural student who went to a small college and didn't take the type of exams that prepare you for medical school evaluation, which, as you and I know, don't predict what type of doctor you're going to be. Right. They just predict how you do on the next standardized exam.
Right.
So, it seems that after the first year of residency, they struggle a bit, but then they're on a level playing ground with their cohorts. And their clinical skills, their community engagement skills, their communication skills, their sensitivity to culture is probably in excess substantially of so many of their American colleagues. So that's the biggest issue, and that's been one of my interests in how to support these students in returning successfully to the U.S. and how to recruit them into our residencies where we need them, and ultimately into our practices where we need them, and how to spread the word so that at least there's not a stigma to training in Cuba. There in fact should be a high level of interest in anyone who is interested in helping underserved communities attract physicians. We should be very interested in doing what we can with these medical students. You still there? Hello?
I'm here, yes.
Sorry, thought I lost you.
Okay. So I had a little disruption on my end as well, just at the same time. So you can pick it up. We can snip this piece out from the middle.
Okay.
So
since we're going to snip, hold on one second, Larry.
Sure.
Is that all right with you?
Yep.
Because my dog is barking because I got someone at the front door who I have to tell that I'm on the phone. Hold on. I'm on a call. I was going to you. Thank you very much. Appreciate it. Great. Thank you. I'll go outside the window. I'm sorry. I'm back with you.
Okay. No problem at all. So your sense is that the students, after they've had a chance to get acclimated and come up to speed in the U.S. hospital-based typical training, that they're able to they compare well with their colleagues before they graduate?
Yeah, that's definitely my sense. There are some things that they excel at. Their clinical skills are superb. Their ability to interact with patients are superb. Their their psychosocial orientation is superb. They just don't have the exposure to the high-tech inpatient type of setting where so much of American medical education takes place, and that's what they need acclimation to. They also need some help, but they're doing much better during medical school in prepping for the step exams and learning how to take those type of tests. But once they get through those initial steps, which primarily happen during the internship year, it's really, they're amongst our most outstanding residents, I would say, from the way that we in family medicine value characteristics of our residents.
So that is great. I appreciate your background and your assessment. Also, I know that you're organizing a trip to Cuba coming up this January. Would you like to comment about that?
Sure. We've been talking about this within STFM for a while. I myself have been down on 6 occasions, most of them through the University of Alabama. And a number of my friends and colleagues in STFM have also been separately. And we've all agreed that there's a lot to be seen and learned from the Cuban healthcare system. Certainly, one of the main reasons to go is to meet a lot of these students and convince the medical educators in the United States by that firsthand exposure that these are remarkable young people who we need to encourage to come back and enter our residencies. But secondly, the Cuban health system, in and of itself, in a resource-poor country, has accomplished a great deal in terms of health outcomes. Their health statistics are comparable and in some places exceed those of the U.S. And this is with a fraction of the cost that we spend in the U.S. And in some areas, like, for example, maternal outcomes, they far exceed our outcomes here in the Deep South, in Alabama, Mississippi, and Louisiana. How have they done this? Can't we learn from a country which really has no resources and look at the things that they have done and apply them in areas like rural Alabama where the resources are similarly scarce?
Right.
I think we can, and that's another thing that I hope we'll take a look at. I'll give you a preview of the answer to how they've done it. It's all about primary care. It's all about family doctors, and it's about universal access to care as well. Now, I'm not delusional to think that America would adopt the Cuban system, lock, stock, and barrel. But again, I think that there are lessons that we can learn that could be applied within the United States, including in how they do the medical education as well as in how they deliver care.
So I so much appreciate having the chance to talk with you. This has been very, very helpful. We will share this information broadly. Are you comfortable with us having your email address out there if people want to follow up, if they have questions and
Sure.
they want to follow up with you?
There's also a link about the STFM trip on the STFM website. There's a page on the website under conferences. If you wanted to add that link for people who may be interested in the trip, that would be great. I can send that to you if you'd like.
That would be great. I'll make sure. Yeah, I'll make sure that we get it as we publish this podcast. We'll make sure that that information is available. So thank you very much for the conversation. This has been wonderful, and I am hoping actually to be one of those people joining you on the trip to Cuba this coming January. So
thank
you very much for organizing it. No, I have not.
Yourself?
I've been to Honduras, and I met some of the Honduran physicians who trained at this school, and I was very impressed. But I've not been to Cuba myself.
Well, you'll enjoy it if you can go. It's a fascinating experience. It's a fascinating country in general, but learning about the healthcare system is really something.
I'm looking forward to it. So once again, thank you very much, and I appreciate your help.
My pleasure. Thank you, Larry.